Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
Hello everyone, welcome back. It's another week and that means another episode of the Research Works podcast. Hi Dana.
Hello Ash, it's good to be back here again.
Yeah.
And today we have a new paper to discuss with our guest, Dr. Stina Oftedal. Welcome Stina.
Thank you for having me.
Today we're going to be talking about your team's recent publication, Stina, titled Brain Lesion Extent, Growth and Body Composition in Children with Cerebral Palsy, which was published in DMCN in June 2025. So that means it really is hot off the press.
Hot off the press. We love that.
Before we get into the details of the article, though, which we are very excited to do, we will tell our listeners a little bit more about you. So Dr. Stina Oftedal is an accredited practicing dietitian and postdoctoral research fellow at the Queensland Cerebral Palsy and Rehabilitation Research Centre at the University of Queensland, specialising in paediatric nutrition and rehabilitation for children with cerebral palsy. Her work has been focused on diet, physical activity and growth outcomes in children with CP, exploring modifiable health behaviours like dietary habits and activity levels, their links to growth, body composition and diet quality in preschoolers with CP.
How fantastic. I love that. This is an area of work that we haven't even delved into yet in this podcast.
No.
Have we?
No. This is
cool.
I mean, we have talked to a dietitian before.
We have.
But not specifically in the area of cerebral palsy.
No.
So this is really exciting for us.
I can't wait to learn from you, Stina.
Yes. But before we do that, Stina, we of course like to do a little informal getting to know you with our icebreaker question. And given that we're talking to a practicing dietitian today, we thought that we would theme our question appropriately. But really, I'm just hoping to get ideas. So, Stina, our icebreaker question, do you have an I'm too busy to cook meal that you secretly love? Oh. I feel like all my meals are I'm too busy to cook meals, but
yeah, it's good to get inspiration.
It's good to get inspiration.
Yeah. Tell us, Stina.
Well, I tend to, I'll either do breakfast for dinner, so bacon, baked beans, eggs,
Great
toast,
brinner.
and,
Yes.
tomatoes, avocados, throw whatever I've got in the fridge in the mix. Or another one that I tend to cook is like I've got a Thermomix, which helps. But like a pasta puttanesca with lentil pasta. So it says high protein, lentils, healthy. And then you got the sauce. It's like 15 minutes.
Oh.
That's probably my two tricks. Yeah.
okay. So what I'm
Not very exciting, but
what I'm hearing is that I need to buy a Thermomix.
Yeah. Is your husband listening to this? I love that your meals, now I feel really bad because mine don't have any nutritional value. Yours has like you thought about the protein, you thought about, just the health and wellness aspect to it.
Practicing dietitian.
Right. So now I should have thought better for this, given you are a practicing dietitian.
It's a judgment-free zone, Dana.
Okay. Well.
Judgment-free, yes, absolutely.
Oh, wait till I say it. So my secret, I love really good food, right? I love really good food, but I also love a bit of shin ramen.
Oh.
Yeah. A bit of an instant noodle.
Yeah.
With a poached egg. And I put in vegetables in there too. And sometimes I put in some meat or some wontons or some dumplings or something like that in there.
Hashtag balance.
Hashtag balance. Thanks. I appreciate that.
Sounds
I
lovely.
don't always finish the noodles, I might say, so I don't have all the carbs, but I just love it, especially when it's a cold wintry night. And my husband and I often say, there's not much in the fridge. I'll be like, that's okay. I've got shin ramen. And it's like my little treat when we're like, haven't got things sorted. And it's kind of really cool. And I've always got stuff in the freezer to bring out to pimp it up a bit.
Yes.
Yeah.
Does it take you back to being a uni student?
It does.
Yeah.
It really does. And even growing up, my family, we didn't go out for meals very much back in the 80s and the 90s. We stayed at home a lot. So sometimes we'd stay at home and our treat was to pick an instant noodle and we'd all cook it around. And it was a bit of a treat. So maybe that's part of it. But a good shin rum and just a bit of broth. I quite like it.
Yeah.
Yeah. I pimp it up though.
Yeah,
Pimp it up.
pimp it up. I like it.
What about
I'll
yours?
write that down.
Thanks.
It's very basic. It's always Brinner. Always breakfast and it's always eggs because they're quick.
Yeah.
And you can, so it's either scrambled eggs if I'm really short on time, or if I've got a little bit extra time but I don't want to spend it cooking, I'll make an omelette. And then just have it with like really crusty sour bread.
Yes.
Sourdough bread. Sour bread. Sourdough toast bread. Avocado. Yum.
See, that is really good.
Yeah.
And if you want to pimp that up with your scrambled egg, you do the little rosette thing, you sort of spin it around in the pan to make that nice shape.
I have tried that a few times. Yeah. I haven't mastered it yet.
Yeah, then when it doesn't work, you just scramble it all up and it's just intentional.
It's fine.
Yeah. Nice. A
All good ideas.
Yep. A nutritional value.
Yes.
Well, thank you for sharing with us. Let's get into the meat of this paper. Can't wait to ask you. I didn't even mean it. Funny unintentionally. Sorry. This is what happens when you talk about food.
Yeah.
You just get a little bit, ahead of myself. All right, let me tell everyone a little bit about what we're talking about. So this study investigated the longitudinal relationship between the extent of brain lesions assessed via semi-quantitative MRI scoring and growth, as well as body composition in a population-based cohort of 124 children with cerebral palsy, aged 18 months to 13 years. So drawing from 359 assessments, the team found that greater global brain lesion scores, along with specific subscores for basal ganglia and brainstem, the corpus callosum and the hemispheric regions, were significantly linked to shorter height, lower weight, and smaller head circumference relative to typically developing peers, after adjusting for factors like gestational age at birth. However, these lesion extents showed no associations with fat mass or fat-free mass indices, suggesting that neurological impacts primarily affect linear growth rather than body composition in this group. So this work highlights the value of quantitative brain imaging in understanding growth challenges in cerebral palsy. Wow.
Very interesting.
Yeah.
It's a bit of a mouthful.
Yeah.
There's lots to unpack there. And like we said, it's not a topic that we have delved into too much on the podcast before.
No.
So, Stina, could you start by giving us a bit of context? Why did you and the team want to look into this relationship between brain lesion extent and growth in children with CP? Where were the gaps and what were you trying to address?
Yeah, so it was really a continuation of my PhD research, which looked at modifiable factors for growth and body composition. So we know that kids with CP grow differently, so they're often shorter and lighter than typically developing kids, and kids that have sort of more motor impairment tend to also fall down the centiles, I guess, on the growth charts, or get the sort of dreaded failure to thrive diagnosis, which, no parent wants to hear. So what we really wanted to look at was, stepping back. So growth and body composition had primarily been looked at in terms of gross motor function and feeding ability, but it hadn't really been investigated how the brain lesion itself impacted growth and body composition. So we really wanted to understand whether growth differences are modifiable, through early intervention and medication, or if it's just some part of it is just a direct non-modifiable consequence of the brain injury. So if that is the case, and it's partly due to that, then that would be quite reassuring for parents to know that they're not really doing anything wrong. It's just how the brain lesion itself is impacting their child's development. So it's the first step of many, but that's what we're trying to achieve.
That's so interesting. And so I suppose just to set the scene, when we're talking about growth in the context of this work, we're talking about linear growth, aren't we? So kind of how tall how tall the child
they grow,
is.
Yeah, but also their weight, so their weight gain and their head growth.
Okay. Yeah. And then body composition is more of the proportions of fat and muscle. Is that right?
So we look at their fat mass and their fat-free mass, and that encompasses both their muscle and bone mass primarily as the two components.
So as you kind of touched on there, the paper talks about altered growth and body composition in CP have been linked to things like feeding difficulties and also the motor impairment. So how does brain imaging fit into this bigger picture? And in particular, the type of scoring that you did on the MRIs, what kind of story does that tell you?
So the scoring system was developed by one of the co-authors, Professor Simona Fiori in Italy, and she scored all of our MRIs. And the scoring tool breaks the brain down into key regions and scores whether or not they have a lesion in that region and how the size of it, and then it gives a total score at the end. Sort of overall extent. So the higher score, the more extensive the brain injury.
Right.
And the benefit of this is that we get a more detailed and nuanced picture of the brain injuries compared to, say, for example, the MRI classification system that says, they've got grey matter injury or white matter injury, which there's such a broad range within those classifications. It's hard to pinpoint to sort of find any relationship within those classifications. So, it really helped us sort of be able to drill down more into the specific brain injury for the children to look at the relationships with growth.
That's so interesting, isn't it? Because I think we've spoken about before, like an MRI, it seems so difficult to be able to quantify, it's descriptive, you'll look at it, people probably, remember being at uni and just sort of sitting around and looking at the MRI to try to describe it, but be able to have this semi-quantitative format of scoring just helps with studies like this to actually relate it to what you're seeing from an outcome perspective.
Yeah.
So interesting. Would have taken a lot of time to do, I imagine.
Absolutely.
Yes. It's been a long time in the making just because how time intensive it is.
Yeah.
Especially when you consider how many data points you actually had, 359 assessments. That's a lot.
Yeah, over a wide age range.
Although we only had to score one MRI per child.
Okay. Yeah, right.
Yeah, so no. But even that was time consuming.
I imagine it would be.
Imagine.
Yeah. Well, do you mind just walking us through your participants now? Because it's a beautiful study with quite a lot of participants. Can you tell us who they were and how you recruited them?
Yeah, so these kids were part of the Queensland CP Child cohort. So they were born in 2006 to 2009 in Queensland. They were recruited from hospitals and health services from all over Queensland. So we got to travel. So this was part of my PhD study cohort, and we got to travel all over Queensland to see these kids, which was quite fun.
Yeah.
And we saw them, they got referred around the time of their diagnosis, which was at that time around 18 to 24 months, so not as early as it is now.
Wow.
And then we saw them around yearly up until they were 5. And then we saw them again for a once-off appointment when they were 8 to 13 for a different study called Predict CP.
Wow.
So it was quite a large cohort of kids.
Yeah.
And we had great follow-up. They kept coming back to see us, which was just really lovely.
That just tells you the value of the research when the participants want to stay involved, especially for a longitudinal research study, right,
Yes.
where there's a greater commitment. But this is quite a long follow-up. So in total, what was that? How many years of follow-up are you up to at the moment?
So we saw them from they were about 18 months till 13 years.
Wow.
So that's, 11
That's decent.
years for the longest ones.
Wow.
And just purely out of curiosity, Stina, can you remember the most remote place you had to travel to? Like how far did you actually go? Queensland's a big place.
Yes, it is, yes.
I think the most remote place I went to was Charleville.
I haven't even heard of
And we flew there on a teeny tiny plane.
Oh.
And it was like you could just see the city of the town, I should say. It was just in the middle of nowhere because you got the great view coming in. There was no clouds.
Wow.
And, yeah, it felt really very remote.
Is that north or?
Yeah. Yes, and inland, yeah.
Wow.
So,
what an opportunity.
It was very hot and dry.
Absolutely, yeah. And what an opportunity to be included in, it'd be quite isolating, I imagine, for those families in smaller towns to have that connection and to have that kind of support and that layering of where to next as well, which is the advantage of being part of studies. Wow, that's very cool, Stina.
Yeah.
So can you talk us through a little bit more about the assessments now? Obviously, I just talked about, MRI as a whole, but do you mind just stepping us through some of the assessments that you did? Because there's a lot of components to this.
Yeah, so I guess the easiest part we did was just measuring the height and weight and head circumference.
Okay.
That was reasonably straightforward, but working with kids that, sometimes can be tricky.
Stay still, let me get the height. Yeah. I imagine so, yes.
But then for body composition, it's quite complicated. So we used what's called the deuterium dilution technique, which is the gold standard. It involves that the parents need to take a urine sample before the child is dosed with a little bit of water that's enriched with deuterium and then taking a urine sample afterwards.
Right.
And there are obviously very many points of this that could go wrong. And then so we also had a backup measure called bioelectrical impedance, or BIA, which is just measuring the impedance using small electrodes. It's completely pain-free, but also requires them to cooperate. But we validated that in the cohort based on the deuterium technique. So for body composition, we had, for the most kids, we had both. For some, we only had one or the other, but we were able to get a fairly good, catch a fairly good amount of body composition measures using that mixture. And then for the follow-up at 8 to 13, when they were older and more cooperative, we used the DEXA machine, which also gave us the ability to catch their bone measurements, which wasn't reported in this paper, but yeah.
Yeah.
So quite a range of complicated measures.
Yeah. But how?
It's also very expensive to get it analysed.
Interesting. Yeah. Well, okay. So how do I say it? Deuterium. So that enables you to get measures of body composition by doing a urine sample.
It measures your total body water. So, and because most of your water is in your fat-free mass, or your muscle and bone, you can see by how much the body absorbs. Now, I'm going to probably get this wrong because it wasn't my job to do the analysis.
That's okay. We don't know any different. So that's right.
That's right.
Yeah. So you put, you measure how much they've had, and then you see how much has been absorbed by a certain point in time, and then you can assess how much fat-free mass they have.
Wow.
I mean, that makes sense to me.
That does make sense to me. And if you don't have a DEXA, or you can't have a child lie down for a DEXA, that makes complete sense to me.
And if you're travelling, to very remote places, you can't take your DEXA with you. So it makes sense to have an alternative. Yeah.
Yeah, and the BIA machine is much more portable and easier to take with you as well.
Yes.
So it was good to have that validated.
Wow. And how long does that process take to use the BIA machine?
5 minutes.
Wow. Okay.
It's really quite quick. You just need the child to be lying still and not touch anything. So we play a lot of
important
caveats, like freeze.
5 minutes as long as.
That's right. Those are a long 5 minutes. Oh, but how interesting to be able to do these kinds of assessments when you're on the road.
Yeah.
Yeah, never heard of them before. That's great. Thanks for sharing that with us.
Thank you. Yeah. Okay, so we have all of these assessments. We have all the data from these assessments. Can you talk to us about the main kind of headline findings from your study? What did you find?
So the strongest relationship that we found was between the MRIs, both the size of it and the regions of it, and height. So the greater the severity of the lesion or the extent of the lesion, the shorter the child was likely to be. There was also an association between the MRI scores and weight and also head circumference. So the brain lesion does influence growth in all dimensions for a child with CP. Whereas we didn't find any association between the MRI measures and body composition.
Interesting.
So, yeah.
And
Sorry,
go on. No, go on.
Well, did any of that surprise you?
Yeah.
I think it surprised me that there was no association with body composition. I think I was expecting there to be some because it's such a feature of CP is altered body composition.
Yeah.
It's sort of found across GMFCS levels, and I was quite surprised that there was no association.
Yeah, especially, when my brain goes to all those studies that we've done on muscle morphology and, that there really is this pronounced difference between
That's right. Good point. Yeah.
children with cerebral palsy, like their muscles compared to a typically developing muscle. We know that they're different.
And they're different really early on.
Yeah. Yeah, so I find that really fascinating.
Yes. So I think they have a brain lesion which makes their body composition different, but the size and extent, like the location of it doesn't seem to, there's no obvious link. So, yeah, it did puzzle me quite a bit.
Yeah. And you also had subscores like basal ganglia, brainstem or hemispheric subscores. Can you talk to us about what they mean? And what you found in relation to those?
Yes, so I'm not a neurologist.
That's okay. Neither am I. That's fine.
So basal ganglia, hemispheric subscores. So those are all regions that are involved in motor control, which is obviously a key feature of CP, and it's closely related to feeding ability. You obviously need to have motor control to eat. Yeah. And it's also sensory and those sorts of things with the brainstem, basal ganglia. But there's also hormonal control in those areas. So there's the endocrine sort of growth hormone control. Yep. There's also appetite control. So those are also all things that could potentially affect growth and body composition. And we did find the strongest association was with height.
That's interesting.
For that.
Isn't it?
Yeah. That seems like an important piece of the puzzle, doesn't it?
It does.
And that makes good sense to me when we initially, talked about that kind of higher level, no immediate relationship between body composition and, extent of brain lesion. But then when you're talking about very specific regions in the brain and the functions that they control, obviously hormones play a really important role in growth and development, don't they?
Yeah, and I don't think we know enough about whether or not any treatment with medication could help. And if you need to start early, but because we've just sort of recently been able to diagnose kids so early and the differences are seen so early. So there's a lot more work that needs to be done in that area, I think.
Yeah. Can I ask you about now GMFCS levels and when you adjusted for gestational age at birth and you described the differences by GMFCS levels, can you talk us through like how this influenced the results? Because I thought that was an interesting part of your paper.
Yeah.
Yeah, so we first looked at just the brain MRI scores and then we introduced GMFCS levels to see how that affected things. So there was quite a lot of difference in the growth between GMFCS levels, even though we had adjusted for the brain scores, which was interesting. And specifically, so the biggest difference was found in height and head circumference. So kids classified GMFCS 3 to 5 were significantly shorter and had smaller heads than typically developing kids. But the only group that was lighter, so their weight wasn't as high, was the GMFCS 4 kids. And we think the reason for that is the fact that they still had so we measured their eating and drinking ability on the EDAX. So that's a similar tool to the GMFCS. And most of these kids had some significant problems with the safety and the efficiency of their feeding. But the GMFCS 4 kids were orally fed, so they ate themselves, whereas the GMFCS 5 kids were predominantly tube fed.
Yeah.
Right.
So we think the difference between those two groups was the feeding mode. So it gets very complicated very quickly.
Yeah.
Because there's so many variables. But we think for the GMFCS 3 to 5s and the height, and there might be an element of their activity levels that is impacting that.
Yeah. So the 4s are still maintaining a level of activity that means that, their body mass is kind of reflected of that a higher activity level relative to a GMFCS 5, but also they are able to orally ingest their food rather than the tube feeding. Because I imagine the tube feeding, can we just talk a little bit about that? Because, I mean, I know it's very nuanced, but I imagine from a body composition perspective with the tube feeding, maybe there's a risk of overfeeding in some instances, or that's something that has to be really closely monitored and that plays a role in body composition.
Yes, absolutely. So we see with the GMFCS 5s that are mostly tube fed, they have a much higher fat mass and it increases significantly with age, whereas so despite the fact that they're gaining weight, their height is not keeping up.
Right.
So,
Yes.
So I would say there's an element of overfeeding there because they might, when you look at a growth chart and you say, oh, the height's not following the chart like they should, maybe they need to have increased feeds, but it's not leading to an increased height gain. It's just leading to an increased fat mass.
Right.
Yeah.
So that's why the kids that are GMFCS 4 and orally fed, they are the lightest kids of the whole cohort.
Yeah.
Because they're not able to eat as efficiently as kids that are a higher functional level. But yeah.
Yeah, because even the eating is hard work for them, right?
That's right.
Like that's almost exercise in itself.
And the time that it takes to get all that nutrition as well.
Yeah.
Would you say that some of the GMFCS, the children who are classified within GMFCS level 4, are they like underweight? You know, you've got the 5s who tend to be on, pegs, and then you've got your 4s who might be taking a long time to eat and get a bit more exhausted before they're even full. Is there an association there? Gets me thinking now.
Yeah. I don't think they're overtly underweight. They're a little bit lighter, but their height is also lower. So
so proportionately.
So it's tricky to say what the perfect what recommendation to make in terms of where they should be sitting.
Yeah.
So their height Z score is lower than their weight Z score. So in terms of they wouldn't look malnourished because they still have a decent amount of weight on their body, but whether or not they would grow more if they had more nutrition, it's hard to say.
Particularly when you think about, if the position of the extent of the lesion is impacting on hormonal factors, it all becomes a very complicated puzzle, doesn't it?
It's very complicated.
But how good is it?
And I'm sorry if I haven't explained it very well.
No, we'll keep asking questions. It's all good. No, but how good is it to tease it out here? Because there's clearly a central component.
Yeah.
And there's a modifiable component almost, when you're talking about even for GMS level 5 in terms of eating, the height and weight charts are probably not that applicable to these children because everything is altered.
No.
So which leads me to my next question, Stina, is what do these findings mean for clinicians when it comes to monitoring growth in children with CP?
I think the clearest finding is that the tube-fed children, we need to be a little bit more on alert in terms of overfeeding because sort of the metabolic impact on like chronic diseases as they grow older, having sort of excess fat mass is not good for their long-term health. And also the fact that they've got less muscle mass but more fat mass makes it even harder for them to move.
Yeah.
So it's not helping in that way. But obviously we need to be careful not to underfeed them either, because that's also it's got significant downsides. But I think that's the clearest message. But also that the children being smaller is not necessarily a red flag. It's part of the CP. So the impacts of their condition, and it might not be anything that we can do necessarily to change that, but we need to do more research to kind of tease out all the bits.
Yeah.
How reassuring for families.
Yeah.
Because it's so true, right? I mean, you hear these stories of going to get weighed and to get measured, and it feels quite, regardless of whether your child has cerebral palsy or not, it feels quite judgy when it comes to height and weight. You know, it can feel that way, right? And so you'll probably be much more sensitive to it because you've been having difficulty with feeding and your child's looking a little bit smaller. It's reassuring to know that there is that relationship that's related to cerebral palsy itself.
Yeah. And I suppose, is there and Dana is a physiotherapist, from a movement perspective, what would your advice be to, physios and people working with particularly these kids, GMFCS level 5, in terms of introducing movement?
Yeah. I haven't stopped thinking about it. Actually, since you started saying that, I'm like, because we really want to try to get them upright against gravity as early as possible for so many reasons, right? To aid in their digestion, to support their breathing. There's so many reasons. But from a physical activity perspective, and getting them to build muscle is just so important.
Yeah.
And, a lot of people say, GMS level 5, can they actually walk in a walker? Well, yes, they can. We've shown they can. You can do so safely. The key is to start early to actually use up energy as well, because they do spend such a large part of their day sitting. So getting them up, using their energy, building muscle mass, and you need to do it before muscle mass inevitably starts to decline as they get older and become more sedentary.
Yes.
And I can only imagine with feeds, if that's not adjusted accordingly, then proportionally those muscles are too small to control a bigger body mass. And then you've got inactivity, and it's very difficult to come back from that.
It becomes a vicious cycle.
It does, yeah. Once you've got too much fat mass and you don't have enough muscle, changing that, modifying that in a child that's GMS level 5 who's maybe 16 or even 20 years old is a lot harder to get that volume of training, I'd say. So this is such an important finding. I can imagine this being something I'll talk about with a lot of our families when it comes to the encouragement of being active and talking to their dietitian.
Yeah. And so at the other, we talk about GMFCS level 5s at one end of the spectrum, but going back to, I suppose, those early flags, is there a particular type of lesion or, a certain lesion type, Stina, that you would say to keep an eye on as potentially, the outcome being poorer growth outcomes later down the track?
I think it's a little bit too early to say. I think the basal ganglia was implicated in multiple of the associations, but it's a little bit too early to say specifically looking at the MRIs which one we should keep an eye on, I think. And we might need some more sophisticated MRIs that we can do these days. These MRIs were taking a while back now, so I think we can probably find out more if we were to repeat a similar study these days.
Yeah, sure. Any advice from here for families, I suppose, in terms of who they're looking at in their team? Like our multidisciplinary team is always, when you try to map it out, it gets bigger and bigger and it can get a bit overwhelming sometimes. But for some of our children here, like obviously by doing this study, you've engaged with a very different multidisciplinary team than who I would normally engage with. Are there any recommendations there for families of who they should engage with or clinicians to engage with if they're noticing, they've got some children who are GMFCS 3, 4, 5, when we're looking at growth and height?
I think what would be really important is to look at both their nutrition and their physical activity. So I think most parents would be linked in with a dietitian, a physio, OT.
Yeah.
But obviously to grow muscles, you'd need both adequate nutrition and they need to be stimulated. So I think those things are probably the most important things in terms of encouraging that healthy body composition.
Yeah.
That's so sort of important for future long-term health.
Yeah, sure.
And continuing to move as they grow older.
Yes, yes.
And starting early.
Yeah.
So those are probably the key things that I would
That's such
encourage.
a good point because we don't often talk to each other.
I might be biased being
I'd
a
say.
dietitian.
I know. But even in saying who we've spoken to on the podcast, I don't think I've liaised with a dietitian in a long time, particularly working in the community.
Yeah.
Like when you're not in the hospital setting and it's something that's a bit more acute or subacute, those conversations don't necessarily come by that naturally anyway. You'd have to really work at building those relationships.
Yeah, but it is a very important,
really important
and constantly evolving piece of the puzzle, I imagine. It's growth and development changes so significantly over, first 18, 25 years of a person's life. So that's something that constantly needs to be considered and adjusted and worked into.
Because we wouldn't do a fitness program without thinking about our nutrition.
No.
We just wouldn't do it.
No.
It would be very unwise to.
It would,
and it wouldn't work very well.
Yeah.
Stina, what about, I've done some studies of DEXAs and, I've gone through the challenge of getting DEXAs for older kids who might be GMFCS 4 and 5, but it feels like a body composition for parents to have knowledge about their child's body composition would be helpful. I mean, is that something that people could think about doing? Like you can get DEXAs relatively easily in a lot of different practices and I don't know, the urine testing. And
how accessible is that?
Is that
no, it's not. No.
DEXA is much preferable.
Okay, clear. All right. But DEXAs, should we be encouraging that at some point in life?
I think it's an important thing to measure and just have an idea of their bone health, their muscle mass, and keeping an eye on whether or not it's improving or not, or if it's getting worse. And then it just gives a nice insight into the sort of inner workings and how a
bit more individualized.
How the child's going in that
way, isn't it? To see what your child's doing.
Yeah, for sure.
I like that. I'd like to get a DEXA, but I'm too scared to.
Because you'd have to test it out? Or?
Well, I don't know if I want to see that percentage. But it'll be good to do. I just need a bit of bravery to do it. But, you do make we did a study recently and we did take some DEXAs and it was really interesting. Like there's some kids were just really muscly and some kids really, they had a lot more adipose than everyone ever realized as well. So it was actually very important for everyone to know that because sometimes children can be really food motivated or they really love their physical activity, but they love their physical activity and they're not having enough nutrition. We've got to be really careful.
Yeah.
Or, there's lots of
eyeballing someone doesn't always tell you that.
No,
when we talk about body composition, I think, we think that you'd be able to pick it, but from a density perspective, it doesn't really give you an idea of density and what is muscle and what is fat and how
really
that changes.
Yeah.
So Stina, where to from here? What's next for? Is there a next step in this work, or what's keeping you busy in your work at the moment?
So some of the work is still in the same vein. So we're following up a cohort of kids that were diagnosed early with CP and had early intervention, and now we're following them up at 4 to 6 years of age, and we're getting their MRIs and measuring their growth and body composition. So to me, it'll be interesting to see if the similar patterns are found in this cohort that have had that earlier diagnosis and intervention versus the older cohort.
So good.
Absolutely.
And then I'm also involved with a study that recruits kids at high chance of CP from birth. So they've had a stroke or HIE or something like that, or very preterm. And then following their growth and feeding difficulties as they grow until they're 2.
Yep.
Which will also help us to hopefully understand a little bit more. And then obviously the running frame intervention, where we're trying to see if, among a lot of other outcomes, see if a 12-week running frame intervention for kids improves their body composition.
We're part of that, yes.
So, you're part of that.
That's good. Yeah. No, I think that's fantastic.
So there's
great work.
Yeah.
Yeah. And really needed, hey? Like in this area, it's really needed.
Yeah.
Congratulations on all of this work and continuing on from your PhD and following on all of this work.
Yeah.
It's so great.
And we look forward to talking to you again about the next paper.
Yeah. There's plenty more to come.
Yeah.
Well, before we wrap it all up, of course, we have to head to our final segment, and he's probably sweating it over there. Oh, yeah, he's signalled he is. Tell it to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he has been listening, and he'll probably have a great question for you. So in about 60 seconds or so, Stina, can you summarise this area of research for someone who doesn't have a background in child health? And Ed, you'll have time for one question. Maybe a follow-up question if you feel like you really need it. But let's go with that. Stina, over to you.
Thank you. I had to write this down so I would remember it.
That's okay.
So we wanted to understand the size and location of brain injuries in children with CP and see if they could explain differences in how they grow. So things like height, weight, body composition, and that is muscle, bone and fat mass. So we followed over 120 children with CP from toddlerhood to early adolescence. We used MRI scans to score how much of the brain was affected and where. And then we tracked their growth and body composition over time. So we found that children with more extensive brain injuries tended to be shorter, lighter, and have smaller head sizes. However, the proportion of muscle, bone and fat in their bodies wasn't directly linked to the size and location of the brain injury. Instead, body composition may be more closely related to how much movement the child can do, and also things like feeding ability and whether or not they're tube fed. So this tells us that growth in children with CP is not just about nutrition, it's also shaped by the brain injury itself. So when a child isn't growing as expected, it may not mean that something is wrong. It could just be part of how the brain injury affects their development. Thank you.
Good summary. Thank you very much. All right, Ed, are you ready?
No, but I'll give it a go.
Go for it.
So it's been a great conversation. I think I followed it mostly pretty well. And I was trying to think of what I could possibly add to the conversation. So it's going to go slightly left field. So obviously you were talking about body composition and then I was thinking about, nutrition specifics. And I remember back when I was a very young man and I was doing lots of training and going to the gym quite often. And I used to think quite a lot about diets and supplements, and relatively recently they have the trending topics of how creatine affects things like brain health and cognitive performance, and it's not just for athletes, and the whole protein for muscle growth and size and all the rest of it. And so my question is there anything kind of on the horizon or that we're aware of that kind of has unique effects for children in this particular population, and what kind of supplements, if anything, can kind of give a better picture on how nutrition works in that group?
Great question.
Ooh.
I wasn't sure if that was a good one or not.
No.
I find it interesting. Stina, over to you. You're the one that has to answer it.
Yeah. I don't know if I have a good answer. I'm not sure that I have specifically read, I haven't, about any supplements to help growth and those sorts of things. It's, I guess, as a dietitian, it comes back to wanting to use real food. Not that I've got anything against creatine. I take it myself. But I think kids in general can meet most of their needs through just a regular everyday diet or a tube feeding if they need to, or blended feeds. I don't think we know enough to say that there's necessarily a supplement they can take. But that's not to say that we won't figure that out in the future. But yeah, making sure there's a balanced diet with enough protein, carbs and fats to support that activity, that's definitely very important. But I'm not sure I'm answering your question.
No, that's okay. I was kind of thinking when I was training, there's a very particular plan about, how much protein I would need as a particular size or doing a particular activity. And I was just wondering whether there was something that was kind of more mapped out for this particular population about their nutritional needs at that micro level.
I don't think so. No, I don't think there's been any studies. I mean, you've got the kids that are tube fed, the dietitians, calculate the protein and carbohydrate, fat in their diets. And even more so when parents are using like blended tube feeds, that's a lot of consideration to go into that. But oftentimes they just blend up, whatever the family's having without overthinking it too much.
Yeah.
So, yeah, I don't think there's been any studies that specifically are looking at
interesting.
Very interesting.
Supplements.
And was that because, it's quite a complex equation, isn't it? You're talking about GMFCS levels, motor presentations, whether they're tube fed or able to feed themselves. There's lots of different things that make it very individualized. And I suppose, that would be
such an incredible thing to think about though, isn't it?
Yeah.
I think of, I've got a 16-year-old GMFCS level 4, loves walking, loves exercising, but it's hard work and her heart rate repeatedly gets above 180. But she loves doing it and she's maintained her physical activity because she's done it so early on. But when she finishes her workout here, essentially, she is so hungry. And so the first thing she'll ask for is usually like, it's Friday, it's fish and chips, or she'll crave these foods, these high caloric foods because she's worked so hard. And I just wonder whether we have our post workout sort of meal and shake, whether she might need something like that. She's obviously craving that, but it's an interesting concept and something interesting to think about. When we think about physical activity and the whole melting pot of stuff. Thank you, Stina, for such a great conversation. It was very thought-provoking. Congratulations on all the work that it took to get to this point as well.
Thank you very much for having me. It's been an honour.
No, we've learned a lot, I think.
Yeah,
so,
absolutely.
Yes, we appreciate your time and your wisdom.
Absolutely, yeah. Thank you very much. So for everyone, we're going to put a link to this paper on researchworks.net, and there's a CPD form there that you can fill out as well if you want to keep this as part of a record of your PD requirements. I've changed the form a little bit so you get a response so you can actually see everything nicely laid out. So if you need it for your auditing purposes, it's a lot easier. And of course, you can also head to researchworks.academy if you want to see, look at this as well. This will be part of our article chat and you'll be able to get more information from that too. So really useful tools of the evidence, I suppose, for what that is. But for all of our listeners, thank you so much for listening. And we'll talk to you all again next time. Bye, everyone.
Bye.